Welcome to Oncology Unscripted. My name is Matt Spraker, a radiation oncologist in Denver, Colorado.
My name is Katie Coleman. I am a kidney cancer patient and patient advocate in Austin, Texas.
And my name is Julie Johnson, and I am a sarcoma patient and patient advocate in St. Louis, Missouri.
We're teaming up to meet in the middle for a candid and educational podcast about cancer that is intended for patients, doctors, and their teams. This show and our opinions are meant for general informational purposes and are not medical advice. We encourage you to reach out to your doctors to discuss your individual case. Thanks for listening. Now let's get on with the show. All right. Welcome back to Oncology Unscripted. I'm very excited for the show. This has been kind of a long time coming. We've talked about it for a while. We have a very special guest with us today. So do you want to go ahead and introduce yourself to the audience here?
Sure. My name is Michelle Hirsch, and I'm a pathologist in Boston. I am the chief of the genitourinary pathology division at Brigham and Women's Hospital and Harvard Medical School, and I am also a gynecologic, or what we call a women's and perinatal pathologist. I did all my training in Boston, but I'm originally from California, so I've been here working for a long time.
That's great. We're super excited to have you, and I can't wait for this discussion. I know that I meet patients all the time that want to know more about what goes on in the world of pathology, which is pretty hidden from patient view. And so this is going to be great to kind of talk about all these things. Maybe we can actually start by talking about what your role is as a pathologist in the multidisciplinary team. I have to admit, I don't always introduce the pathologist to the patient as part of the team. And so maybe you can kind of share with us kind of what your role is when you work with other oncologists or cancer doctors and what you do.
Sure. So I think it's important to understand that there are actually different types of pathologists, and the two general categories that we talk about are those that are called clinical pathologist and anatomic pathologist. And the way I simplistically think about it is a clinical pathologist deals with test tubes and liquids. They often do urines, blood work, etc. And then an anatomic pathologist does work with tissues and will analyze specimens, and that can include anything that comes from surgery to someone doing an autopsy. And so the latter is what I do. I'm an anatomic pathologist. I was trained in what's called anatomic or surgical pathology, and so I just deal with the tissues, and somebody else does with the liquid-based specimens. And my role as a pathologist is first and foremost is to diagnose entities. And that can range from anything that's a benign diagnosis to a malignant or cancerous diagnosis. Sometimes it also includes things infectious possibilities, even infertility-related specimens where patients are having a hard time getting pregnant, et cetera. And so basically on a day-to-day basis, I'm working with myself with the slides, but we can talk more about that in a little bit. But you receive slides that you look at down the microscope to make your diagnosis. And I'm either doing that myself, or because I work in an academic center, most frequently I'm doing that with a trainee, which could be either a resident who's training in pathology or a fellow who may be subspecializing in genitourinary or GYN pathology. And we form diagnoses. And then I take that diagnosis and I issue a pathology report, which is then sent to the clinician who can use that information to talk with the patient. And again, I'm sure we'll talk about more of this in detail, but that information gets to the clinician who can then communicate that information directly to the patient. As part of the clinical care team goes, we have a lot of interactions with the clinicians, but very infrequently with the patients directly. And so we do a lot of things. For example, we can have tumor board. This morning I had a tumor board where radiation oncologists, medical oncologists, urologists, and the pathologists get together and we discuss certain cases and situations and talk about how that patient would be best treated. So that's one way. We also have just educational conferences where we're together. And then also, for example, in the field of GU pathology, we do what's called a PIRAD conference, where we're actually looking at a QA to see if there was something called on radiology that is discordant or doesn't sync up with what we see pathologically. We meet to talk about why that might have been missed on radiology and sort of help to give them feedback. So there's lots of interactions that we can have. And I talk to the clinicians on a day-to-day basis. I might call with a result. I might call and ask for some clinical history. So there's tons of interaction that we have, lots of email interaction, but we really are part of the clinical team. We field a part of the clinical team. And I certainly am in a really conducive environment where at least the people I work with include us in that conversation. But you're absolutely right. When it comes face to face with patients, we're not there very often. Only about a handful of times a year do I talk to a patient. And it's probably true that most of even my really good colleagues may not discuss who I am or what I do to their patients on a day-to-day basis.
It's really hard to overstate the importance of pathology in cancer care. Like it's like we have jokes, we say like tissue is the issue, or we make these like rhymes about how important it is. But it's you are physicians that like are so important for what we do because every single recommendation we make essentially stems from pathology. And it's a real privilege that like when you're in a place that has very strong pathology, you can actually go back and ask them questions. Or like when you pointed out, sometimes when we have radiology stuff that if you put it together with pathology, like not everything's matching and it might be very confusing. That's where like I think your field is so important. Before we dive into more details about it, I wanted to ask a quick question about just training. So you mentioned clinical and anatomic pathologists. So those all those people go to medical school, and then do they all do the same residency? Is that
Yes, so not necessarily. So you're right, we're all medical doctors. And I will say that there are people in the field of pathology who do clinical care who have PhDs instead of MDs. So there are some roles, a lot of the geneticists are PhDs. So it's not always a medical doctor, but when we're talking about clinical pathology, anatomic pathology, that is primarily medical doctors. So we attend medical school, and then like any doctor who comes out of medical school and would do a residency in surgery or medicine or orthopedics or whatever their choice of subspecialty, pathology is a choice as well. And you do your pathology residency, and you have a choice when you apply to a residency program to choose anatomic pathology or clinical pathology or both. And it's really your option and your choice. And then you do X amount of years of training, depending on if you do one or both. And then you take, exams at the end to get board certified in that area. So I personally only did anatomic pathology and chose not to do CP. And then what ends up happening is in academic centers, it's more frequent that someone practices AP or CP only and not both, but it can be that some do that. And then in community hospitals or smaller private practices where there's fewer people, they often will hold AP and CP degrees, and they will do both of those things in that hospital.
And then I'm guessing you probably did you do a fellowship as well?
I did.
Okay, yeah, because I know that just I guess for the audience, so like both Katie and Julie have rare cancers, and like so when I actually worked where Julie was treated and we kind of worked together, I had a fellowship trained sarcoma pathologist. It's like it's a niche thing that they're expert in, and so that's additional training over the residency. And I'm guessing you have that for the pelvic cancers that you mentioned.
That is correct. So I did fellowship training after my general residency in anatomic pathology. I did fellowship training in both gynecologic and genitourinary pathology. And then that's where I did my job. Took my job afterwards at the Brigham, practicing both of those subspecialties. And again, it's mostly based on number of people and size of departments, that in larger academic centers, it's easier to subspecialize. So a lot of times you'll have a pathologist who just practices one or two areas like myself. It doesn't mean I don't know other things, because you have to recognize, for example, colon cancer can metastasize to the ovary. So I still have to be able to recognize that GI pathology, those GI pathology features, because I might see it in an ovary and I need to recognize that it's not a primary ovarian tumor. So we still have from our general training sort of a general understanding. If something looks like lymphoma, it's really nice. I can walk down the hall and show the hematopathologist, I think this is lymphoma. Can you help me? So we're really lucky that we have so many subspecialized pathologists. And as you said, with Julie's, sarcomas and soft tissue pathology is extremely difficult and subspecialized. So you're usually going to find those types of experts in an academic center. And then the community hospitals and the private practices have people who have trained in general pathology. And many of them will do a subspecialty fellowship, and then they'll go to a practice where they sort of see everything and do everything, but they might have a little bit of expertise training and be the go-to person in that practice for a certain area.
Speaks to the complexity of the field, I think. I think, again, it's like kind of hidden to patients, but you need, I mean, it's a ton of training. It's as much training as all the other oncologists get in your
Yep.
field that you do. Yeah.
So I did 4 years of training, and it was really 5 years in total with some research as well added. So yeah, it's a lot of work, and but it is, when you can be sort of more focused on an area. I mean, I think you can fine tune, the details, the clinical pathologic correlation that comes up in what we diagnose, and which is what I like to try and teach my trainees, that it's not just looking at a slide and saying it's A, B, C, or D as a diagnosis. What's really important for me and my work and what I teach is, of course, what's the diagnosis, but also how is that going to affect the treatment of the patient? And I learned that from these multidisciplinary meetings that we have with my clinical colleagues, because if I call something A, I need to know that it's going to affect a patient in a certain way. And if I call it something else, that might affect them totally differently. So it's really important for me to understand that in the background as I'm doing my work, so that I know the consequences of what I'm saying. And it's easier to do that, and you can have a more fine-tuned understanding of that when you're subspecialized versus having to know all of pathology head to toe. It gets diluted out a little bit. You can still be a very good pathologist, but it gets diluted out. And that's why people will sometimes seek out these expert opinions. They know the more fine-tuned details.
So talking about the importance of pathology when it comes to patient care, and we have highlighted on a previous episode talking about tumor board and how all of these different disciplines come together to discuss the case. I know my case was discussed at tumor board, and a pathologist was a part of that tumor board. But also, Julie, I thought this might tie in well with your case, because I know you had several different pathology opinions as well. I think I had 3. I'm not sure if you had 3 as well, too. And I think it specifically, since we both have rare cancers and what came out of that changed the treatment plan for each of us, I thought it might be interesting to share, if you're willing to, Julie, from your side, and how you evaluated your pathology and your second opinions, because I believe it did change the treatment outcome for you, right?
Yeah, so in my case, I had 4 different pathology opinions, because it took 4 in order for me to get 2 opinions that aligned with each other. And in fact, it wasn't as though the 4 opinions were, all in the sarcoma realm either. There was an opinion that it perhaps was not sarcoma that I was dealing with. And so I needed to get some of these other pathology opinions to help me figure out how to navigate the differences. And, as a patient thinking back through that, it was really confusing, because I was trying to understand something that I didn't have any connection into. So Michelle, you talked about this, like there's no patient connection back to the pathologist where I could maybe probe deeper on some of the nuance that was certainly playing a role in the various opinions that were happening in my case. We've talked before on the podcast that Matt was my radiation oncologist. And I don't know if you remember this, Matt, but you were kind enough, probably because I kept asking so many questions about pathology, that you did actually set up a consult for me to talk to the pathologist at the center where I was treated. And it, like, I had been struggling with this for months, and that one conversation helped me immensely just get to a place where I felt like I could move forward in treatment, and I could kind of resolve the differences that were in play with the case. So, I know you talked about patients being, or pathology kind of being behind the curtain and patients not having a glimpse into it. And I think it's really important. And I would love to hear you talk about, what happens when the tissue is, there's the tissue removal, and then there's the point of the patient learning about that opinion. And in the middle of those 2 time points, there's so much important work that's happening that I'd just love to hear you talk about the process of that and what actually is happening between those 2 time points.
Sure. So I'm happy to talk about all that. I'm going to break it down a little bit and first just say I'm so glad that Matt did get you in touch with your pathologist. It's certainly not part of our daily routine or a daily setup. We don't have clinics where we see patients, but I do know that myself, and I do talk to about a handful of patients a year. There are quite a few number of pathologists who are always happy to speak to the patients about their information. So I certainly would encourage anyone who has questions about their pathology report. Certainly you can start with your primary clinician, but if you want to speak with your pathologist, you should always either ask for a connection through your clinician, or, you can Google me and find me online, or somebody, whoever your pathologist is, and try and find out where they are and call that department and to say that you would like to get a message to them, that you would like to spend some time talking with your pathologist. I really think, I can't say it for 100% of pathologists, but those that I work with and my colleagues around the country and the world, I don't know anyone that I can think of who would say no to speaking with a patient. So it's not the norm, but we're always happy to speak with patients and help them understand what they're going through from the pathology directive perspective. That's one thing. So what happens is, and certainly I also wanted to say that, like, I completely sympathize with there are the day-to-day, I talk a lot when I train pathologists and such about the bell-shaped curve. And it is the majority of the cases that we see fall within the middle of the bell-shaped curve, and they are straightforward diagnoses. And of course, both you, Katie, and Julie have unfortunately had to deal with uncertainties and rare diagnoses, which makes it challenging. You're on the ends of the bell-shaped curve. But we do a lot that is more routine, that can be put out there. But I really feel for patients who have to go through this sort of uncertainty when a pathology report is not so definitive, or when you just do get a pathology report with different information in it. That's not, like you said, you had to have 4 reports for 2 people to agree. That must be really, really hard and frustrating and confusing already when you're dealing with an emotional situation. So I really have a lot of empathy for that. And certainly we try to minimize those sorts of reports that are less conclusive as often as possible. So having said that, how we put this all together from the beginning to the end when you see the report is basically a patient will go in and have some sort of procedure, and that could be a biopsy of a percutaneous biopsy by an interventional radiologist, meaning through the skin. It could be a skin biopsy. It could be a prostate biopsy, a breast biopsy, a kidney biopsy. Any of these are options, and those are usually smaller pieces of tissue that we work with, and we get those fragments or whatever is taken as a biopsy, and we will process it. And those can actually process relatively quickly, where we have to take the tissue, we receive the tissue from the clinicians who have removed it, and we do a 24-hour processing. And the example that I always use is, if you take tissue from a patient from whatever site, you can imagine just your arm or your skin is kind of soft and squishy. And so it's very hard. We have to look at tissue cut in extremely thin sections for us to be able to see the details of the cells down the microscope. So the example that I use is, if you used a very, very overripe tomato and tried to take a slice of a very overripe tomato, you can imagine when you cut it, it's very hard to get a very, very thin slice of that because it'll squish and break apart. But if you took an underripe tomato that's extremely hard and then wanted to cut a very, very thin section, that is much easier to do. So what we do in the processing when we receive the tissue is we take a piece of tissue which is soft and a little bit squishy, and we process it in a way that makes it very hard, so that we can then cut extremely thin sections of that tissue to be able to look at it down the microscope. And basically, we use formalin to fix molecules and particles which are in the cell. It sort of locks them in shape and locks them in place. And this is a 24-hour processing that we do through various formulas and liquids. The details are not so important. And then the next day, once that's happened, we take the tissue and we put it in a hot wax. It's a little boat and it's a little square section. And you put the tissue in the boat, the little area, and you put in hot liquid, like if you were melting a candle. And when you put that, it will solidify in the square with the tissue in it. When you put it and make it cold, it then becomes a hard square piece of plastic. And we call that a block. So patients may hear that they needed their pathology sent somewhere and they need their slides and their blocks. And it's sort of, what's a block, right? And a block is just that. It's a square piece of paraffin or wax and plastic. And that's where we put the tissue in it. We had hot kind of paraffin, which is liquid and goes around it. When it solidifies, it's now a square little block. And that shape of that block and the way it's been solidified can be mounted onto a specific type of knife. It's called a microtome. It's a machine that holds the block, and then they slice with that machine extremely thin. It's called 4 microns. It's very, very thin. You could actually probably see through it if you held it up. And that gets cut from this, again, like cutting a very ripe or underripe or hard tomato into a very thin section, which then gets laid down onto a glass slide, which is another rectangular piece of glass. And the size of it corresponds with the size of the block. So that tissue is now laying on the slide. And then just as if you were working, I don't mean to minimize it in what it is because it's so important, but really it's like arts and crafts. It's dipping a slide in different types of solutions that is just basically staining the tissue. It's applying colors to the tissue. And we're sort of see things as pink and blue based on the products that are in the cell itself. And then once that staining is done, we can now look at it down the microscope. And if it's a biopsy, as I started out talking about, it's a small piece of tissue, it's usually 1 block. But if it's a resection, an organ resection, if it's a mastectomy, or if it's a nephrectomy where the kidney is taken out, or a colectomy, or a hysterectomy, where all these ectomies means the entire organ is coming out. Now we have to start by looking at those organs, and we will take measurements of all the sizes, and we will usually photograph the specimen, and we document everything we're seeing. And we will even apply ink to the outside of the specimen because we have to know when we're looking down the microscope, is it something the surgeon cut or is it something we cut in half? So we need to know because, of course, the patients want to know, is a margin positive or negative? Did the surgeon cut all the way around it? But if they cut with a knife and I cut with a knife, you can't tell the difference. So we will apply ink, or it's like a paint, to the outside of these organs, and that's where the surgeon cut. So then if we look at something down the microscope, if it has blue ink on it, I know that's where the surgeon cut. If there's no ink on it, then I know that's where I cut. But we will take these organs and we cut out smaller and smaller pieces, and we are trained on what to take. For example, of course, we're going to take an area of the tumor, but we also will take a little square piece that is the tumor and next to the tissue. So in a kidney is often a very round mass. We will take a piece that is half tumor, half kidney. And then it's small enough to fit in that block and be made into a block. Because we want to see sometimes, is a tumor infiltrating or invading through the tissue next to it? Is it going all the way to the margin where we inked it, where the surgeon is? So we are trained on what pieces to take because we can't put through an entire uterus or an entire kidney to look at down the microscope. It would be too much material. And we don't need all of that to make the diagnosis. So we will sample accordingly. We take these designated areas, but then the processing is exactly the same. These tissues go in a 24-hour processor to become harder. They get embedded in that paraffin wax to make a little block, and then that block is mounted and tissue is cut very thinly. We stain those slides, and then we look at those slides and then issue the report based on what we're seeing down the microscope. So it is a process and it takes time.
And to be clear too, the edge part where you're inking, you're actually inking different edges to identify like this is the superior or front edge or back edge or left edge or right, because that actually matters too. So it's more
Sure.
than, yeah,
Yeah, it depends on the specimen.
yeah.
So for example, on a thyroid, it doesn't matter what side it is. So they'll do one color on the entire thyroid. On the outside of an ovary or the outside of a kidney, it's all one color. We only need one color. But we do use two colors for prostate, one for the left side, one for the right side. The most ink that we use is, at least at our institution, and places have their own protocols, but we use 6 colors for breast. So if it is a lumpectomy specimen, that is fatty tissue that comes from someone's breast, you can't tell what is top and bottom. You can't, so you have to keep an orientation. So the surgeon will actually send us a lumpectomy specimen, a portion of someone's breast, and they will put a stitch, a piece of string on it, and they will say the long string is the top and the short string is the right, or they'll give us some orientation, and then we can apply the ink in 6 colors so that when we look down the microscope, we're looking, is it at the red ink or the blue ink or the green ink? And then we can say, as you said, is it the top, is it the bottom, is it outside, or is it inside? And then that can help guide if additional therapy is needed or if radiation therapy is needed, where it should be directed. So absolutely, but it's different for every specimen.
Yeah, I thought maybe it'd even be kind of neat to talk about because I got to see some of this process happen last week, and to share from a patient perspective. I am somebody who, kind of like Julie, because we had such rare cases and we were on the edge cases of that, I completely dove into my pathology report and learned every staining. I've even requested to know like how much tissue I have left stored somewhere. And I've heard over and over things like, oh, you have X number of blocks, or when my biopsy tissue ran out of tissue, like that's the language that they used, was like, there's no more slices off the block. And it was really neat to actually see that in person. So I might share some examples from like kidney cancer, for example, to share some of this perspective from. So when you talk about those little blocks, so I know for a patient, I had a very large tumor. I had a 12 centimeter tumor, right? And so when I asked how much tissue was stored, I was told that most of it was stored. There was a lot of tissue that was stored from my tumor in particular being so rare as well. But I, in my mind, always thought, okay, I saw the image of my tumor when it came out from surgery, and I saw this big tumor, and I saw exactly what you said when they slice it open. And I thought that is how it might have been stored, or sections of it stored like that. And the piece that I found very interesting visiting and seeing it actually, what those blocks are, is how tiny they actually are. So to me, I was trying to think of a comparison to compare it to it. Like, to me, they look like kind of like half of a Post-it note is kind of like the size that you might expect them to be. And that's like the wax around it. And so the tumor tissue inside of it is much smaller than that as well, too. And so I remember hearing all the time of like when I sent my slides from Huntsman Cancer Institute, and I got a second pathology opinion at MD Anderson, and they said, okay, they requested 13 slides, and it was X number of slices off the block. And it was really neat to actually see that in person, to see what that meant. I thought the slices would be like, kind of as you described it, honestly, of like slicing a tomato. I thought they'd be these like thicker slices that go on something, but seeing it in person, that machine, it's probably a terrible analogy, but it literally reminded me kind of like of a roast beef slicer. Like, it's
Cutting
like,
very thin salami. Like it's
yes.
just really, really thin. Any of those. I mean, it is truth. That's exactly what it's like. There's a blade and you're running it down just as if you were doing that. So I agree. It is a little bit strange to think about, but it is exactly like that.
Yeah, and it was neat for me to see because as somebody who had my tissue exhausted before from a biopsy, and I had a fine needle biopsy, which meant there was even less tissue, which explains why it was exhausted. I was always so worried about like, oh, how many slices off the block can they take? And so to see this in person and see like, oh, there's hundreds of slices in one of those blocks. And when one of those slices comes off of the block, to see it, it kind of sits on top of some solution,
Water,
this
it's
basin
water.
that
Just when they cut
water.
it, it's right into a water bath. It's just
Okay,
pure
water
water.
bath.
Yep.
Yeah, so it was neat to see that kind of lay on top and see that that's how it's transferred onto those slides that I think a lot of people have seen kind of those slides before as kind of the small glass slides, and to see how that process actually happens. And then all those machines that you talked about of how you're figuring out the stainings, to be able to see those machines and how it moved along the process. And for me, one of the things that I found interesting was that the H&E staining was like a separate process than, for example, the IHC stainings, and they were kind of in separate areas, and to learn the differences between those. So I even thought maybe that could be a nice segue.
Just before we move on to that, so try not to, I don't want to make you lose your thought, but just so people have a perspective of this little square block, you could fit a nickel in it, and maybe, I've never tried, so I'm guessing, but you definitely could not fit anything bigger than a quarter. That's how small they are. So it's a nickel to a quarter in size, what goes in there. So when you have a 12 centimeter mass in the kidney, we certainly can't put that all in that one block. So it has to be cut into smaller pieces. And just to sort of say, we are, again, there's protocols and residents, and we train people. I was trained when I was a trainee, and we pass it forward, is, you take, for example, in a kidney, the ureter margin, the renal vein margin, the renal artery margin, those margins go in one cassette. And then we are taught the standard of care is 1 block per centimeter of tumor. So for your case, you should have had your margins of the vessels and the ureter in 1 block. And then at minimum, you should have had, if your kidney tumor was 12 centimeters in size, there should be 12 additional pieces of tumor. Sometimes you can put 2 pieces of tumor in 1 block. So you might not always have equal number of blocks, but we have to take sections of tissue. Standard of care is one piece of tissue per centimeter of the mass. And that is so we know that, and we will pick different areas that look different to our naked eye, because we want to see how those look different down the microscope. So you don't want to just pick one area that looks all the same. You want to kind of move around and take different areas. So that's sort of standard. So if you have a biopsy, is going to be 1 block most of the time. If it's a bladder biopsy, it could be a lot of tissue that turns into 3 blocks or 5 blocks, but it's fewer. For organ resections, you're usually about 10 at minimum, and then it depends on the details for that organ system. So just to put it in perspective for people.
That's super helpful context. I think that, like, especially the analogy for like a nickel or a quarter, to imagine what those were, because it was so hard for me as a patient to like picture what that was. I'd hear it so many times, but hard to picture it.
I'm really glad you brought that up, because I didn't have a mental reference for when someone said block. I didn't have a mental reference for that. I always kind of thought like a Rubik's cube.
Oh yeah, definitely. It's much thinner. It's only, half a centimeter in depth, really.
Yeah.
So
yeah. And so before I kind of segue over to the other piece of that, I actually do have a question about that. So you mentioned about 1 block per centimeter of tumor tissue for clinical use. What happens with all of those? So say you have a tumor like mine, so you've got 12 blocks. After you've done the initial diagnosis and you're looking at tissue from maybe each of those blocks, what is done with the rest of the tissue that's remaining? Does that stay at the original institution, or what happens afterwards with that?
yeah, it's a really good question. So unfortunately, we do not have the capability to store everyone's tissue forever. It's not possible, because we get in so much every single day. So the rules generally are, we never discard anybody's tissue until the pathology report is final. So because sometimes I'm looking at a case and I see something down the microscope, or maybe the ink wasn't in the right, where I expected it to be, or they forgot to take the margin. So we always keep that specimen while we're doing the pathology workup, because we call it going back to the bucket. And so if we can go back to the bucket and take more. So maybe we took 12 blocks, and I'm not sure I have enough to finish my diagnosis, so I could go put through 5 more or 10 more. Or sometimes if someone's had neoadjuvant chemotherapy, which to treat their tumor, which of course the hope is to make as much go away as possible. And occasionally it all goes away, and that's great news. But I don't always know that until I've put through a lot. So if I put through 10 blocks and I can't find any tumor after neoadjuvant therapy, I'll go put through more, and sometimes the entire bladder or whatever specimen I'm looking at, to make sure that I don't miss anything. So we have that ability. We always keep the specimen while we're working up the case. Now, I should also mention, for patients who consent to research, sometimes part of the tumor can be taken before our workup or during our workup and would be stored in a tumor bank or with a specific researcher. So some of the tissue can go to research when a patient allows that to happen. But when we're talking about the regular pathology workup, if I have taken all the tissue I need and I've rendered a diagnosis and I'm satisfied with what is done, we usually will keep the specimen for another, I believe at the Brigham, we keep it for 2 months. And then it does get discarded and incinerated. So at that point, the tissue, which is the main organ that we were working off of, is gone, because that will be discarded. The rule, at least in Massachusetts, is, and I'm not sure if each state is what the rules are in every state, but you have to keep the blocks for 10 years. So the tissue is always available in those blocks, if it hasn't been exhausted, that you can go back and do new studies or special studies off of the tissue. So what we've put into those little blocks in the wax, we keep those for, again, by law for 10 years. At the Brigham, we keep them forever. So we never get rid of the blocks. But the remainder of the specimen that we didn't use or didn't put into blocks, that has to be discarded. And so we keep everything else. Smaller hospitals, again, at 10 years, they may throw those blocks away because of storage issues and money.
I have a quick question about patients' ability to know how much tissue an institution has in storage for their case. And I ran into a situation where I wanted to do some, I'll just say, like, probably non-standard testing using my tissue, but I really wanted to make sure we did not exhaust all of my tissue on these tests. And so I went to the pathology department kind of on my own, and honestly, my oncologist did too, to ask how many, like, what is in inventory. And as a patient, I was trying to do this before I went to my oncologist to talk about these tests, because I really wanted to make sure that it was worth the conversation and I had the tissue and it wasn't going to exhaust it. But I was really surprised how challenging it was for me as a patient to learn about my inventory. And I don't know if that's just me and the institution I was working at, or if that's like that's something broader and more of an industry thing. I was wondering if you could just speak to any regulations around sharing with patients about their tissue inventory.
So I will qualify by the fact that I have not ever looked into the legal side of it all, but I believe personally that it's your tissue, it's your diagnosis, it's your cancer, and you do have some say about that. We like to keep track of it, so we don't like to just give out blocks and tissue or slides to everyone, because if we did that and then it never comes back and now you want something else done. So there is sort of some record keeping, of course, and some forms that have to be filled out and consent, et cetera, when things go from one place to another or a patient wants to pick up their tissue. But I do believe that if a patient wants to do something, that they have the right? This is for you and for your diagnosis. Having said that, to know what the quote unquote inventory is or how much was taken at the time of workup should be in your pathology report. So the majority of pathology, everyone can be slightly different in what shows up on their report, but generally speaking, the top of the report has your diagnosis. It will say pathologic diagnosis, tells you what your cancer is and your details about your cancer. And then lower down in the document, it will say gross description. And gross means the big specimen. That's what we mean by gross. It's the terminology that we use is the whole thing. And there may be a paragraph that says, this organ came in, this kidney came in, and it measured A by C by D, or A by B by C centimeters. And it was, the ureter was this long, and we opened it up and there was a mass that was so big. And so we give this gross description and we describe what we're seeing. We talk about what we ink before we take the tissue for these blocks. And then underneath that paragraph where we're describing what we're seeing, there should be what we call a microscopic key. Or a micro key is what we call it for short. And it will say micro key, and then it will say block A1 is the margin. Block A2 through A6 is the tumor, and block A7 is the margin. And you should be able to add up, depending, some people use the alphabet, some people use numbers. But you can pretty much see that if from that microscopic key should tell you exactly how many blocks were made from your specimen. So you should be able to read that and say 12 blocks were taken, the inventory that they have. Now, there may not be tumor in all 12 blocks because some of them are margins and making sure that the tumor is away from those areas. But a lot of times there's 6, again, depending on the size of the mass, 5, 6, 7 different blocks that represent tumor. And it will say tumor to normal kidney, tumor, or tumor to normal breast tissue, or tumor to skin. And so as long as that word tumor is in there somehow, you can count up, and that will tell you what your inventory is.
Yeah, I found similar issues to Julie when I was trying to request how much I had left too, because as a patient, part of me was, I did see some of those things in my pathology report, but then also for me especially knowing I had a rare case, I knew it was like evaluated a bunch of different times. I knew they used tissue for different testing. And so part of it was like, how much is left after all of that has been done? And I think, Julie, I don't know if you ran into some of the same issues. I think part of it too is that patients usually don't ask. And so I think also there isn't really a great process. And so it's a question that they might not have heard before, and they don't know who they need to go to get the right approvals to find out where it's stored, how much is left, and how they can share it. That's kind of what I experienced as I was trying to track down that information. Is a lot of times it was like trying to figure out who the right person to ask is to know, like, can they even share that information as part of it. One of the other things that I thought would be interesting to touch on is, so when so going back a little bit to stainings as well as like what's captured in the pathology report. So I know for kidney cancer, for example, and I know we kind of talked about this as well too. So renal cell carcinoma, PAX8 is often listed as kind of what helps differentiate that as a renal cell carcinoma, I believe, and kind of helps you know that started from the kidney. But then there's additional stainings that patients might find in their reports. So for example, for chromophobe kidney cancer, that can be IHC stainings of CK7 or CD117, as well as, so those are IHC stainings, I believe. And then there's other features such as like grading, how aggressive the cells look. And one of the things that I wanted to touch on that I found really interesting when we were chatting was, for example, part of going, I believe, into grading is also like necrosis. Do you see necrosis in the tissue? And I know one question that I had for you was how you would evaluate the percentage of necrosis that is seen in a pathology report. And I see that in some patients' reports, and then other patients just have reported that they just have necrosis, for example. So I was wondering if you could share a little bit about the differences between how pathologists might kind of write those reports or what's written in those reports, and how you tell how much you're including or different practices, sharing some of those details too.
Sure. So again, a lot of little parts in that, but we'll try to break it down. So generally speaking, again, a lot of what we can do in pathology, whether you're talking about, again, colon cancer, liver cancer, breast cancer, kidney cancer, there are sort of standards that are general rules. And the general concept, what we're looking for is first. And of course, is it, even if we're talking just in the tumor world and sort of leave infectious things out of it, or other types of biopsies we may see for other reasons. But in the world of tumors, we want to say, is there or is there not tumor in the case? Sort of the first thing we'll put. And then the second thing is it benign? Because some tumors are benign, or is it malignant? And even whether you're benign or malignant, there are subtypes. So we have, like you're saying with your situation, Katie, it's like there's renal cell carcinoma is a general category of malignant cancers in the kidney. But then there's about 24 different subtypes. And so we have to not only say that, yes, this is a primary kidney tumor, but what subtype is it? Because if that tumor spreads, it can be treated differently based on the subtype. So it's my job to say, A, as the example I was saying before, is this primary, meaning did it start in the kidney? Or if I'm looking in an ovary, did this start in the ovary or did it come from the colon and go to the ovary? So whether it started there or it metastasized to that organ is really important. And if we start with just talk about if it started in that organ, then you not only, the sort of standard things we will include is, again, that it's the primary tumor, what is the subtype, what's the size of the tumor, and these pieces of information can be helpful for one, radiology clinical correlation, but also some tumors staging is based on size. Breast cancer, not sarcomas of the breast so much, but epithelial ductal breast cancer, the size of the tumor is part of the staging system. So when you're looking to stage, it really matters. Was it greater, and I don't know the staging for breast cancer by heart, but is it more or less than 3 centimeters? Kidney cancer, is it more or less than 7 centimeters? Changes the stage. So those are important size. But then we're also going to, and again, across the board for most of these tumors, is there a grade? And it's different grading systems. In kidney, we use a 4-tiered grading system. In colon cancer, they use a 3-tiered system. And then sarcomas, sometimes they just talk about if it's a well-differentiated, poor differentiated, or they'll just talk about risk. Some of the soft tissue tumors, you have a tumor that is of low risk or high risk. And basically, all kinds of translational or clinical research is done to sort of determine these things. And once people study and say, if there are more than 10 mitoses per 10 high-powered fields, that is a poor prognostic indicator, then we'll put it in the report. But until we knew it had clinical value, it might not have been a report. So this is always ongoing and evolving. As we learn more and more, some pathology reports from 10, 15 years ago might have slightly different information than what we know now, because we've determined with research and clinical research that a piece of the puzzle is important or not important. And necrosis is one of those things. So not every cancer tumor, when I'm looking at endometrial cancers and ovarian cancers, I don't mention necrosis. I look for it because it can help me make my diagnosis, but there's nothing prognostic about it. So we don't mention it in the report at all. But in clear cell renal cell carcinoma, there are studies that have shown that the presence of necrosis is prognostic. So we mention that necrosis is present. But it's challenging, and Katie, you brought it up on how you determine how much necrosis is present, because when we've talked about grossing in a specimen or putting specimens into those little blocks, I tell the residents, don't take a lot of necrosis, because I can't make necrosis, for anyone who doesn't understand, is dead tissue. Okay. You can't make good diagnoses on dead tissue. You want to make it on viable tumor, on viable alive tumor. So I'm teaching them specifically to take pieces of tissue that are not necrotic. So you might have 10 blocks of tumor and one has a little bit of necrosis in it, but the kidney mass itself might have a lot of necrosis when you look at it grossly. So it's very hard to quantitate how much, because 1 out of 10 blocks would be 10%, but maybe 50% of the tumor mass was necrosis, but I've told the residents not to sample those areas. So the question really comes down to, does the amount of necrosis matter? And in clear cell renal cell carcinoma, it's not about the amount. And so it's really about the presence or absence. So Katie had told me she's seen some reports where they'll say 10, 20, 30% necrosis. I would question the accuracy based on how much you see down the microscope versus did you look at both the microscope and the specimen itself before a pathologist called 30%? And then secondly, so how accurate is that? But even does it matter? And so I don't report percent of necrosis. I just say it's present or not present, period. So again, it sort of can vary from organ to organ, but generally speaking, it's the diagnosis, the subtype, the size. Is it confined to the organ or has it spread outside of the organ? That's a staging issue. Is it at margins? When I look at prostate cancer, if there's a lot of tumor at the margin, then a patient could receive external beam radiation following their surgery because they had a positive margin versus a negative margin. So that's standard in every report. We talk about whether tumor is present or not at margins. So again, there's sort of generalized standard things we all include, but then from organ system to organ system, and lymphomas, melanomas, carcinomas, sarcomas have different criterias. And there's a lot of work that's put into guidelines. The CAP sets up guidelines. ICCR sets up guidelines as to what should be included. And pathologists and clinicians will get together and talk about what guidelines should be used. And again, it could vary and vary. And you can look these up online in different documents. But again, standards, tumor, size, if it's confined to the organ, does it spread out, et cetera, the information that's involved. Is it in lymph nodes? Sometimes colon cancer, we always look for lymph nodes. Is it spread to lymph nodes or not? All of that would be included in the pathology report.
Yeah, I thought I wanted to highlight the necrosis one in particular because that one was one that I found very eye-opening. I think Julie and I both talked about how we like pored over our pathology reports and tried to understand every word. And that to me is something that I can imagine like a patient reading that in their report versus having the conversation with a pathologist. You'll notice that was like a very different explanation of like, if you're really worried that it might have said 20% necrosis, or if it might have said more necrosis, understanding that there can be kind of nuance between that and between the pathology reports is super important.
So necrosis in sarcomas is really important for making the diagnosis of a malignant sarcoma. Soft tissue tumors that don't have necrosis are less frequently malignant. So that's, again, just helping us make the diagnosis. But even in kidney cancer, there's a lot of really aggressive kidney cancers that have zero necrosis. So again, it can vary from subtype, and part of it is a diagnostic feature. So it's helping me. If I'm looking at a smooth muscle tumor in the uterus, benign smooth muscle tumors, which are called fibroids, don't have necrosis. But a fibroid can become malignant. It's called a leiomyosarcoma. And having the presence of necrosis really helps me distinguish a benign smooth muscle tumor, a fibroid, from the malignant smooth muscle tumor, which is a leiomyosarcoma. So sometimes it's just a diagnostic feature and not a prognostic feature, which are two different things. They can be both, but are also two different things. So
In the
sorry.
sarcoma world, it's extremely controversial, the value of necrosis about how prognostic it is or not. And I
Yeah.
think they've been arguing back and forth for like a decade at this point or longer about how much that, affects the prognosis of the patient. But as you said, it's much more accepted as like a diagnostic feature. And that's a really great point, I think, for people to hear. Yeah.
Yeah, it's also really important to understand that more and more patients are getting neoadjuvant therapies before resection of their tumor, neoadjuvant bladder, neoadjuvant breast, neoadjuvant ovarian tumors, or they're getting radiation, SBRT and radiation therapy of these tumors before they get it resected. And so then you have to talk about, is the necrosis prognostic? Because a tumor that is aggressive might have sort of this self-dying, self-destructive form of necrosis, versus inducing death of the tumor by treating it. And so tumors can undergo necrosis, and that's sort of the intent with the treatment before you take it out. And is that necrosis have the same prognostic value if it's after neoadjuvant therapies? And that's also very challenging because I don't think people know the answer.
For those listening that might not know what neoadjuvant is either, I know that was something that I struggled with as a patient. So neoadjuvant is before you might have surgery or kind of an intervention to take the tumors out. And adjuvant treatment is treatment that may happen after, but before it has reoccurred. Am I correct in that terminology
Absolutely.
there?
Yep. Thank you
Okay.
for clarifying. Yeah, absolutely.
Perfect. The other thing that I wanted to mention is from your description, you also talked about one of the primary things for all cancers that you're trying to workup is the organ that it came from. Is that the H&E staining? I think people may have heard of H&E staining before. Is that what you use to determine the organ that it came from?
Yeah, so absolutely can be. So H&E stands for hematoxylin and eosin, and one is a pink dye and one is a blue dye, and we use those together to help us see the details of the cells and the details of the tissue. And it is the standard of care. Looking at an H&E stain slides help us, what we say, see the histology of the tissue, or we also use the word the morphology. And at the end of the day, I always say, I'm a morphologist first. So it's morphology, morphology, morphology. And that's just, we say that in pathology. It's like we look at that H&E and we learn and know so much from looking at it. So you can definitely look at some tumors. And we call, when a tumor looks like its native organ, that is called well differentiated. When it looks nothing like its native organ, that's called poorly differentiated. And then somewhere in between that is called moderately differentiated. So if a tumor is very well differentiated, I can look at it and say, yes, that is definitively from the prostate, only from the H&E slide, and I know that. But if it has become poorly differentiated and doesn't look like the native organ, then sometimes I need a special stain to say that this is prostate and not bladder, or this is from the GYN tract and not from the breast. And so that's when we use immunohistochemistry. So we always start with the H&E and we form what we call is a differential diagnosis. A differential diagnosis says, I'm looking at my H&E slide, the morphology of the tissue, and I am forming what I think it is, my impression. And I will say, my first choice is this, my second choice is this, and my third choice is this. And if it's like, again, prostate cancer and very obvious, that's my first choice and my only choice. But sometimes you can have overlap. Sometimes tumors from two different organs can look extremely similar and that can be just that they look similar or because they're poorly differentiated. A poorly differentiated lung cancer and a poorly differentiated breast cancer can look identical. So then we need help above and beyond the H&E stain slide. And the most commonly used tool for that is called immunohistochemistry. And basically, immunohistochemistry is looking for a tag, okay? We're doing a protocol, a technique that says breast cancer expresses proteins on the cells that are specific to breast. And lung cancer expresses proteins on the cells that are specific to lung. And we can't see them with the naked eye. So we apply a solution that has what's called an antibody, and the antibody will stick to that protein. It's called an antigen, but the antibody will stick to the antigen or the protein, and then we can use a detection system to see it. Okay, and that's the simplest form of what immunohistochemistry is. Put an antibody on the tissue, and it will turn brown if it's expressing if it's the antibody to the breast cancer, it will be brown in the breast cancer. And if you put the antibody to lung on that same tissue, it will not be brown. So by looking at so I'll use the specific names. The antibody we use for breast cancer is called GATA3, and for lung is called TTF1. It's Katie, what you said earlier for kidney is PAX8. And these are transcription factors, and these are transcription factors are usually involved with development of tissues. So these are proteins, genes and proteins that are expressed in the development of the human body from the embryo on. And if they're used to develop the GU system, PAX8 helps develop the kidney at the biologic level, and tumors from the kidney express PAX8. So we can put this antibody on the tissue if we think it's a kidney tumor, and if it turns brown, then yes, it's a kidney tumor. And if it was GATA3 on breast or TTF1 on lung, and these are transcription factors that help us say, where is the tumor coming from? Now, if you're in a lymph node and you have no idea where it's coming from, I could put all three of those, and presumably the one that if TTF1 is positive and the other two are negative, then I know it's lung cancer. Now, the thing that's really important to understand is that some of these antibodies say, where is the tumor coming from? And then other antibodies are used to say, what is the subtype? And you talked about that earlier. CD117, or KIT as we call it, helps us determine the subtype, but doesn't tell us where it's coming from, because there's a sarcoma called a gastrointestinal stromal tumor, and it expresses KIT, but so does chromophobe renal cell carcinoma. So we have to use the H&E, or the morphology that we're looking at, to say, do we think it's a sarcoma or do we think it's a kidney tumor? And if we need to, we can use the PAX8 to say it's kidney. And then we know if it's KIT positive, it's a kidney tumor subtype and not this GIST, or gastrointestinal stromal tumor. And so these antibodies can be used for saying, where do I come from? They can be helped for what's the subtyping. And there also can be used as prognostic or therapeutic biomarkers. And it's a lot to get into, but people may have heard, especially in breast cancer, Herceptin, HER2 testing is just the same technique. We put the antibody to HER2 on the tissue. If it's positive, you are HER2 positive or estrogen receptor positive. Based on this immunohistochemistry technique, and that could guide whether a patient gets either tamoxifen or Herceptin therapy. So those are tests that we're doing the immunohistochemistry for, not to make the diagnosis, but to help guide the treatment. PD-L1 is another one that's used quite frequently nowadays. So we use this a lot of the time, and the way I always approach using immunohistochemistry is I'm looking for a question. Is it tumor from this site? And then I pick the antibody that I've learned to represent that site. I apply it. And if it's positive, I can say yes. And if it's negative, I have to think about something else. The other thing that I want to say, these transcription factors, for example, stain more than one site. So PAX8, as the example, is important for embryogenesis of the kidney and the thyroid and the Mullerian tract. So if I have a tumor in a lymph node or at a metastatic site and it is PAX8 positive, that could be a GYN tumor or a kidney tumor or a thyroid tumor. So then I need to use more stains, more antibodies to say which of those 3 sites is it coming from, and then some of the subtyping as well. So these are all things we're taught, all things we're learned, and we usually will do immunohistochemistry in a panel, usually anywhere from 2 to 5 to 8. And in really hard cases, Julie, I imagine with your sarcoma, you probably had a lot of antibodies put on yours because you were not getting to an answer, and they will try everything.
So, what's been really interesting is through this, I've pulled up, as we've been talking, I've pulled up my pathology report next to this, and I've just been kind of revisiting it as you've mentioned some of these things, just to see what was mentioned and what wasn't mentioned. And you're right, there's a million stains that were used. And it actually leads me to a question. Sometimes people talk about how little tissue they might have after, maybe it's just a biopsy, maybe they didn't do a full resection, they were just able to get biopsy material. And so once you go through and you do all of this staining, is that tissue after it's stained kind of rendered unusable again? Or can you use it for other analyses after it's been stained with all these IHC stains?
So when we do the immunostains, they're on a slide. So it's just like your H&E slide. You'll have your H&E slide, and then there'll be 10 more immunostain slides. So they will be, you'll have, if it's a biopsy, say you have 1 H&E, and then you have 10 immunostains. So you'll have 11 slides in total, and you really can't do much more with those because they've already been cut, they've already been stained, they've been cover slipped, and you're just going to use those to look at. What's important is what's left in the paraffin block. And this is what I had showed Katie when I met her last week and saw with her last week, is depending on the size of the tissue, if I have something the size of a nickel and it is 3 millimeters in depth in that wax, in that block, I can get 50 to 100 tissue sections off of that. And then you've got 10 immunostain slides.
Yeah.
I could still cut enough for molecular testing, enough for prognostic testing, and doing a whole lot of other things when you get a nice big piece of tissue. But if you have an FNA or a core biopsy and you're getting basically, sorry, I can't. If you have a core biopsy and it's a small, thin I mean, it's like drawing with a pencil. If you took a pencil and drew 1 centimeter in length, that's the size of a core biopsy. So it's 2 millimeters in width and 10 millimeters in length. And that you are not going to get as many sections of. So you
Yeah.
might only get 20 tissue sections out of something like that, depending on how big it is. I will also say with a core biopsy, so for example, if you have a mass in the kidney, and you're going through the skin or however they're getting there, and you go into the kidney first, if you go into the mass 2 millimeters, I might have 10 millimeters of tissue with 2 millimeters of tumor, versus if the needle got pushed further, I might have all 10 millimeters of tumor. So it can matter. We always look at the H&E first, because you could have a lot of tissue on a slide with a very small amount of tumor. So you could go through that tissue much quicker if there's small amounts. And we are conscientious when we do it. I don't just start and say, here's the tissue, and I'm going to order 20 immunostains up front because I have no idea what it is. Again, I'm always developing a question and that says that I'm using the immunostains to answer. So I might cut 10 tissue sections for immunostains, but only use 3. And then if those 3 work, I'm done. And if they don't work, I had a case today and I did 6 immunostains and it didn't tell me what the tumor was. So tomorrow I'm doing more. So I had to order some more slides and do some more. And if we have a case that's, again, straightforward, we can get there quite quickly. Maybe I almost never do one. So say 2 or 3 immunostains. But in a case like yours, especially with an undifferentiated or unclassified sarcoma, we are going to try and try and try. And you keep putting more and more and more on it, hoping to get to the final and specific answer. So if it's a biopsy, you could run out of tissue. If it's a big piece of tissue, there should, like, again, from a resection, you should have enough for molecular. But again, we're conscientious about it. I know a lot of these tumors are going for molecular testing these days, so I'm not going to waste the tissue if I don't have to on getting to a diagnosis with those immunostains. So we try to conserve what we can. But what's left is in the block, not on the slides.
It's probably worth saying too that in rare cases, you may not get to a definitive answer, right? I like to tell patients that tumors don't read textbooks and they turn into whatever they turn into. And it seems really rare these days, but like we do get cases once in a while where even if we like badger the pathologist, they'll just tell us, look, here's what I think it is, but it could be this thing too. And this is the best I can do with the tests available to us today.
I did have an inconclusive. So my first biopsy came back as inconclusive, and I had to go back for what was a lumpectomy. And I remember I had no idea that was an option for me to have an inconclusive biopsy. So I remember I was waiting for my physician to call, and when she called to tell me it was inconclusive, it was like, well, that wasn't even an option that was in the realm of possibility in my mind. And I remember her saying, we need to take out the full mass so the pathologist can go through slice by slice and evaluate the entire mass to make sure that we're getting to the right diagnosis.
So certainly the intent, I'm sure, of the clinicians, even before it gets to me, right, is to be as the least invasive and the least disruptive that they can to get to the diagnosis. So if we can do a core biopsy and get there, we talked about necrosis. Sometimes if the needle goes directly into the necrotic tissue and you do get tissue, but it's all necrotic, I can't make a diagnosis. So they actually got into it, but it makes it really hard. And so, but the intent, because sometimes tumors will come back as with benign diagnoses, and then you don't have to go to surgery. So many times it's to sort of distinguish is it benign? Is it malignant? Is it something that should have treatment, neoadjuvant treatment before it's resected or after it's resected? Can we use some studies to say how it should be treated? And so but you're right. Sometimes they do come back inconclusive. And Matt, I say tumors don't read textbooks to my trainees all the time. All the time. I say it in every lecture that I give to, when I'm teaching, because we have to remember these are not perfect. And I'll tell you, I signed out a case today, and Katie won't like hearing it because I couldn't get there, but I had to say I favor oncocytoma, but I cannot exclude a low-grade renal cell carcinoma because I could not be conclusive. And I even did molecular testing, genetic testing on it, and we could not get to a final diagnosis. So I had to equivocate and say, I'm pretty sure it's benign, but I'm not 100%. And I will relay that information. And I'm humbled enough to say I don't know all the time. Either A, we don't have the right test for it. Tumors can be smarter than we are, or they don't read the textbooks. And so we do have to, and I'm sure it's very frustrating for patients when they do, either it's inconclusive and the pathologist says rebiopsy is needed to make a diagnosis, or when we just can't be specific about it. But it can be challenging in a smaller subset of cases. And I diagnosed one today, could not be conclusive.
One of the things I was hoping that we could talk about just is, I remember when I got my pathology reports back, I was pouring through them like Katie mentioned as well. And at the time, I remember sitting at my kitchen table late at night, just Googling every term and phrase that was on the pathology report, trying to make sense of it. Because I wanted to learn about what was happening in my case. And so when you have patients like that, I would just love to know if you have any resources or how, if a patient really wants to understand their pathology report, what kind of guidance can you give? What resources are out there to really help patients understand what's in their report?
Yeah. So it is really hard because medicine in general, pathology included, has its own language. And that's not the lay language. And so there's some of it which is more obvious than other words. And so first and foremost, I'd say certainly ask your provider, whoever your primary caregiver is. If you don't know what a word means, you should definitely ask. But, sometimes you can't get them right away, and you really are trying to get to that information first. I will come full circle to the beginning of this discussion and say, get online and try and find your pathologist, and feel free to ask your pathologist if you have questions. For sure, reach out to them. We will talk to you. We have no problem, and we're happy to talk to you and describe what that means as best we can to you. But there is Google, and that is in today's day and age, the internet is certainly going to be one of the ways to do it. You do have to be a little careful because getting the definition of one word can lead you down the rabbit hole, and you may be like, it's telling me what it is, but I don't understand those words either. And it just makes it even more confusing. So, but I do think you can get some descriptors online. And then there are, at least from the pathology, which is more specialized to medicine in general, there are a lot of websites you can go to. Certainly the American Cancer Association has lots of terminology websites. Individual institutions, the Brigham has their cancer center websites, Mayo Clinic, lots of resources. And when you Google these things, those places will come up. And will give you information that you can read about a certain cancer subtype. There are pathology-directed websites that I think are a little bit more lay in terminology, but they are still directed a lot of times to pathologists. One is Pathology Outlines, and it's just that, the word pathologyoutlines.com, and it is a very short 1-page to 2-page description of what a tumor type is, whether it's benign, malignant, what it looks like down the microscope, what immunostains might be used for that specific tumor type. And I think it's a relatively easy read. However, there will be words in there that are specific pathology type terms that make it really hard for people to understand, and you're still going to have to look those up. The College of American Pathology has some guidelines. There's UpToDate and WebMD. So there's various places you can go. The WHO, which is the World Health Organization, puts out what we call a blue book every few years, and it is specific to tumor. So again, pathology is not only about tumors, but when we're talking in the field of tumors, the WHO, again, each tumor type, and there's a book for the organ system, like there's a GU blue book, a GYN blue book, a soft tissue and sarcoma blue book, a neuropathology or neuro blue book. And in that, you can have 1 to 2 pages that will give you a really nice brief description about each of these tumor types. The problem with that is you have to either buy the blue book or pay to subscribe to it to get to that information. So there would be a fee associated. It's like buying a textbook, if you will. But it is a quick read, and I think it's a simpler read than a lot of, going to some big research articles about a certain entity. So there are resources, certainly starting with talking to your provider. And again, reach out to your pathologist if you need it. We're always happy to explain it.
Yeah, I think all those are great resources. I know I used pathologyoutlines.com myself as I was trying to learn because I really liked that they had the kidney cancers that you could dive into specifically. And when I had my differential diagnosis, so you mentioned earlier how you might have a couple different diagnoses you're trying to kind of rule out. I had chromophobe kidney cancer, hybrid tumors, and oncocytoma in there. And so I was able to see through pathologyoutlines.com the specifics of kind of each one of those. And for me, it was helpful. I'm just a very visual person. And so being able to see an image of what they were talking about for like eosinophilic chromophobe, for example, and how that might look different than classic chromophobe and those kinds of things. So I really like that you kind of shared all of those different ones in case patients. I know for me as a patient, sometimes there's just like something almost empowering about seeing the thing of what is being described in your pathology report. At least there was for me. Not every patient is like that.
What I will say is some of what you'll find on those things like pathology outlines, like say you're looking up a specific type of kidney tumor, and the person who wrote that page about a specific type of kidney tumor, again, there's more than one way to get to the final diagnosis. And so I'm just going to use an antibody that I never use, which is called Vimentin. And Vimentin is used by a lot of people in subtyping kidney cancers. And I don't find it a necessary antibody to get to my diagnosis, but other people were taught to use it. So if you read something on pathology outlines and it says you have a certain tumor type and you need to use Pax8, CK7, KIT, and Vimentin, and then your pathology report doesn't have Vimentin in it, it's not to say that someone did something wrong. It's just that they may list 10 or 12 antibodies that are present or absent in a certain tumor type, but you don't always need all 10 or 12 of those to get to the diagnosis. And as we talked about earlier, if I'm trying to preserve tissue, I don't waste it on a Vimentin because it doesn't help me personally in what I'm doing to make the diagnosis. So again, there'll be sometimes more listed than you may find in your pathology report. And again, that's okay because people do things slightly different. So you're seeing lots of options there that may or may not be used by 2 or 3 different pathologists.
Yeah, I think that's excellent context for those sites as well too.
Pathology really has a big impact on the way that we decide to treat people. And so sometimes patients will ask me, well, how sure are you that what they're telling you is right? And I think one question I sometimes bring up is if, especially in the case of like rare cancers, we sometimes talk about getting a second pathology opinion. And a lot of times it's easy if it comes from me. So I have a mechanism where if my multidisciplinary team decides that we want to verify a diagnosis or get a second opinion, often it comes up for like a rare cancer, like sarcoma is a great example. We'll send it out to a big center that I know has a really big program where they do a lot of sarcoma pathology, and they might be able to review that for us and give them their opinion. But what if it comes from like a patient? So what if they just want to be really sure, even if it's something where their doctor's telling them, look, we do prostate cancer all the time, there's no need to get a second opinion. I personally disagree with that, but what would you say to a patient if they like wanted to kind of initiate getting a second opinion on their pathology? So they're going to stay with their treatment team, but they just want to have a second opinion about whether the diagnosis was correct.
Right. So it's a great question and it's super important. And the bottom line is, I will just say simply, if you want a second opinion, get one. Like, I think everybody has a right to want a second opinion. I'm never offended if somebody wants to have my case that I've signed out looked at by somebody else. I think that's completely fair. And as you said, if a patient has been diagnosed at another hospital and now they're coming to my hospital, we will re-review that for our treating clinicians. And there is that mechanism where the treating clinicians will request the slides to be sent to us, and we will then look at the slides and render a second opinion. If a patient wants a second opinion, either because of that's just how they feel, or because it was an ambiguous diagnosis. And certainly if it's an unclear diagnosis, or if there are words in there that are hedging a little bit. I called today renal oncocytic neoplasm not otherwise specified. That is not a definitive diagnosis, but chromophobe renal cell carcinoma is very definitive. And so if something isn't fitting right, or something isn't, or it's just not clear and you want it to be sent to somebody else, first you have to know who you want to send it to. So that could be word of mouth. You could ask your provider, who else would you suggest besides the pathologist here to look at this? They may or may not have a pathologist name that they can help provide. You can Google online and see, who's at different institutions, but you send it to someone potentially who has specific experience in that field. Then you're going to call up your own institution and just call the pathology department and say, I'm interested in having my slides sent to that's why you need to know upfront who you want to send it to. Because if you just say, I want a second opinion, and you're calling the pathology department that has their slides, they need to know where to send it and who to send it to. They'll ask you to sign a consent form that you're agreeing to have your material sent to another institution or to another pathologist. And then it's done. It's basically should be sent out at that point. Most institutions will send the slides only, and they might send a subset of the slides, or they might send the entire case. And that can vary from place to place. I had a case that I read yesterday that was 2 out of 12 prostate cores were sent to me, and I read them and I made my diagnosis, and the patient has now, through their clinician, asked me to call for the rest of the case and get the other 10 slides. So we're going to get the other 10 slides and review the entire case. So that's okay as well. But some institutions just upfront will send parts of a case. But they usually will send the slides first. And if I can look at the slides and make the diagnosis, I will with the H&E. But then if I need to do more stains or special studies, I will then call for the blocks. You don't have to, if you get the blocks up front, that's fine. Most institutions, many institutions won't send all the slides and blocks up front. They don't want to lose the tissue. They want to kind of keep hold of some, because sometimes if it doesn't ever get back to them, they want to make sure they maintain some of it. But basically, for a patient to initiate it, they would call their pathology department, give their information, their consent form, and where they want the slides and to whom they want the slides sent to. And you can then say, please send this out, and I would like to have a second opinion. That second opinion will be rendered, a pathology report will be made, and typically under those circumstances, because we can't create the pathology report with the patient's name as the referring physician, they'll either place the original pathologist, or you can tell them your primary care doctor. So Matt, your patient could say, I'm having this sent to Michelle at the Brigham, but we could put your name on it as the referring physician. So then the pathology report come back to you, then you can share that with your patient. So I really think it's important. I think any patient has the right. If it's very clear cut and straightforward, sometimes you can tell that from the pathology report. If it's a really common diagnosis, then people are, again, if we're working in the middle of the bell-shaped curve, you're going to get it right. Hopefully people a lot of the time. It's those outliers that are much more difficult. Other situations, prostate cancer, you mentioned, is an extremely subjective grading system. Subjective means fuzzy gray. It's not a black and white grading system. What somebody else calls in prostate cancer, we give a formula for grading. So it's a 3 + 4 = 7, which is a grade group 2 cancer. And calling that 3 + 4 is based on architecture, what we're seeing down the microscope. And what someone else sees as a 3 + 4, I might see as a 3 + 3 = 6 grade group 1, or vice versa. So it's very subjective, and that's very frustrating for patients, because they will have their original diagnosis, they will go to the other institution to be treated, and they'll get a second diagnosis. And now they have still have prostate cancer. The baseline is the same, but the grade is different. And that's probably one of the areas where there's a lot of variability in pathology reports. So you might send it to a third pathologist to say which one's right. And in many ways, you might get slightly different, even on the third one, because of the subjectivity. Other grading systems are much more black and white, and you can be very clear that this is a grade 3 kidney cancer. But prostate's very subjective, and people definitely, and it can affect the management. If you have Gleason pattern 5, it really makes a difference. And there's a lot of artifact that I believe people overcall Gleason pattern 5. So I downgrade it. And that can affect management. So you might want another opinion on that. And everybody deserves it because it's your care and it's your case, it's your situation, and it's your right for sure to get a second opinion.
Yeah, I think it's a very important question to ask along with thinking about a second opinion is you should definitely ask your oncologist how it would affect what they do, because sometimes it won't, right? And so one thing I think that wasn't mentioned is it's probably true that at most places they will get a bill for this, right? Because it is a service. You're a doctor that's doing work on it. And so I've had patients where they'll get a second opinion. They're sometimes surprised to get a bill from that institution. It's just because, you sent it there and you want them to do work, so you will get a bill for it. And so I try to tell patients, like, I'm always very supportive of second opinions. I just want to make sure that the time, effort, and money that you're spending is going to pay off in changing what happens. Because if it's not going to at all, then I think sometimes it's really nice to know. But at the same time, if it's not going to change what we do, then it's sort of like, it doesn't really
For
make.
sure.
Yeah.
If somebody calls a kidney cancer that's confined to the kidney, and so therefore it's a PT1, stage 1 kidney cancer confined to the kidney, and one person calls it grade 2 and the next person calls it grade 3, that won't change anything. And so they're going to be treated exactly the same. You're right. And so I think that it is important to understand if it will change. The subtype in an unclassified sarcoma, like Julie's situation, trying to get to a classified state to find the actual subtype, that is super helpful. If a kidney cancer is called renal cell carcinoma unclassified and you want someone to help you get to a more definitive answers, those can have effect. But there are small details that may not change management. So I agree with you completely. That's important. A lot of insurance companies, I believe, will still cover second opinions, but obviously that is patient to patient. And insurance company to insurance company. So it's important to kind of look at and find out, or maybe call your insurance company and see if they'll cover the second opinion. So.
Yeah, I think we had another episode on second opinions from a clinical perspective. And I think this kind of fits in with that. And what you both touched on is really important of asking your oncologist, for example, if you're saying your oncologist or maybe your surgeon who might have given you the initial diagnosis, if they think it's worth a second opinion. Being a stage 4 patient, for example, I obviously had a really rare case, but being stage 4, for example, if you have widespread disease and you have a more common type of cancer, it might not be necessary to go for a second opinion. It might be more crucial to get started on treatment. And so understanding the context of when it is helpful to go for that second opinion and when it's not, I think it can be really helpful for that entire care team. And that involves your pathologist, that involves your oncologist, and all of that to help tease out that information. So I always want to make sure that we highlight those areas as well too, just since Julie and I do have such rare cases, it can sometimes make it sound like almost every patient might need one. And I want to make sure that some patients know that if you might have a little bit more common one, every patient probably deserves the ability, if they want one, to get one, but also making sure that you don't kind of interrupt your own care if it, again, as we just talked about, won't change the treatment decisions.
Agreed.
Awesome. Well, I think this was an excellent episode. Thank you so much for joining us. I know this one was one that Julie and I have been dying to do for the longest time. And I learned so much from you last week that was just incredible to learn about this area that patients don't get access to very often.
As it delivered on the hype, it was a great episode. I think it's fantastic. All the things you went through are going to be super helpful for people. Yeah,
I hope so. And it's really nice. I mean, pathologists really love what they do. It's an unusual or less, maybe not unusual. It's a less common subspecialty in medicine. And so fewer people go into it. So I think those that do it really enjoy it and care about it and And so we really feel and want to be part of the clinical team, and it can be frustrating at times. So we're happy to be included. We're happy to spread the information and put it out there that, pathologists are a part of your clinical team. And again, you can always advocate for yourself and ask to speak with us. I mean, Katie said at the beginning, asking questions, whether it's directly to your provider or from other people, support groups, people in a similar situation, asking questions really just helps with knowledge on all levels. And the pathologist is always there to help as best we can with everyone in that regard, even though we don't see patients on a day-to-day basis routinely. So
awesome. Well, thank you so much. And we will keep you posted as we wrap up. And I know at the beginning of the episode, we also talked about other areas of pathology, including like molecular testing and other areas as well, too, which might lead into future episodes. But it was excellent having you on, and thank you for all the information you've shared.
It's my pleasure.
Yeah.